All right. Hello, I am Dio Jaobi, and I'll be co-hosting this event with Dr. Stephan Serban on behalf of the Harvard School of the T.H. Chan Harvard School of Public Health and the Harvard Club UK. I'm a senior consultant pediatrician at the Hammersmith Hospital, which is one of the Imperial College Healthcare NHS Trust hospitals. I graduated from the School of Public Health and I did epidemiology as well. And I'm on the engagement committee for the Alumni Association of the Harvard School of Public Health, and I'm also a member of the Harvard Club. I'll hand over the screen to Dr. Stephan Serban to introduce himself before I go ahead and introduce our guest speaker.
Thank you very much, Tayo. Trying to see the screen. Yeah. So hello, everyone. My name is Stephan Serban. I'm the chair of the Specialist Interest Group in Healthcare of Harvard Club UK. Currently, I'm working as a final year specialty registrar or resident in dental public health in Leeds in the north of England. Thank you very much for joining us today. It's great to see you all here, and I'll hand over to Dayo. Thank you.
All right, our guest speaker. We're here this evening to engage you in reality of these unprecedented times. Catastrophic scenes have occurred, and they've unfolded in our very eyes over the last several weeks. And to discuss, we are here also to discuss the predictions of the future. Our guest speaker is a global expert on the evolution and the epidemiology of the COVID-19 pandemic. He's an associate professor of epidemiology at the Harvard T.H. Chan School of Public Health, and is a faculty member in the Center for Communicable Disease Dynamics of Harvard. Prior to Harvard, he was at the University of Oxford, and he was also at Imperial College. He has authored over 140 papers on topics from the H1N1 influenza pandemic in 2009, and also works on the emergence of new species in bacteria. He combines his cutting-edge research on the ongoing coronavirus pandemic with keeping governments and the public informed of the science and reality behind the pandemic as it unravels before his eyes. The latter is now showcased in his high-profile editorials in national papers. And he's also had several interviews with respected institutions and organizations, such as the US Chamber of Commerce Foundation, where he spoke on the roadmap to reopening up the US economy. He's one of the most respected experts working on the science and epidemiology of the COVID pandemic. I welcome Dr. Bill Hanage. We will be having a short conversation with us on the theme, Peak or Peaks? Epidemiological features of the coronavirus pandemic, where are we now and where are we headed? We look forward to hearing his thoughts. So let me go straight into the discussion. Do you mind calling you Bill?
Not at all. Please, go ahead.
What has been your personal and professional journey so far on this COVID pandemic?
Thank you for the very, very kind introduction. Diana, I wanted to point out, I didn't realize you were at Hammersmith. That's where I did my PhD.
Okay.
If you stand and say hi to her.
So we come a long way.
Yeah. So I think that my personal journey in this started sometime in January, which was when our center, which has meetings we used to have meetings every Friday, and the faculty kind of looked at each other and just said, you know what, do you think we should talk about this thing that's going on in China? And we stopped what we were doing that day and we talked about what was going on in China. And we talked again and again about what was going on in China. And at the time, the focus of the questions that we were asking each other was, do we really believe this is the true spectrum of severity? What is the true infection fatality rate? What is, there must be a whole huge number of, unsampled, unnoticed, mild infections. And we kept talking about that. And I was sort of neurotically looking every morning at reports from exported cases, trying to estimate whatever I could from them. And very early on, this would have been either late, I'm going to say it's late January. I noticed that the serial interval, which is the time between subsequent cases being reported, was about 5 days. And the incubation period was 14 days, was estimated at 14 days. Now, the combination of those numbers put together suggests that transmission is happening quite early on. And so that was the first hunch that I got, that there was likely either pre-symptomatic transmission or maybe asymptomatic. I think there's always been a lot of confusion between asymptomatic and pre-symptomatic. They're not the same thing. Pre-symptomatic means that you may be unwittingly transmitting the virus. You don't know you've got it now, but you will then develop symptoms later, but you've transmitted beforehand. And I think that was around the end of January, because if I look through my private messages, there's one dated January 28th in which I make the comment that this would have been declared a pandemic already by WHO were it not for swine flu. Because if you're old enough to remember swine flu, then the pandemic was declared on the basis of transmission in multiple WHO regions. And a lot of people reacted quite strongly to that. But as we all know, the severity of swine flu was not particularly dangerous. It was not a high pathogenicity flu virus in the same way that, say, 1918-19 was. And that led to, and I was speculating that was leading to a certain amount of restraint. Anyway, around that time, you could see that the cases were plummeting in Wuhan, largely as a result of the very, very strong measures which were taken by the Chinese government. And we wondered to ourselves, would it be able to be confined to China? And I remember quite distinctly saying in a meeting, what if somebody is walking through an airport right now and they are mildly infected and they don't know they've got it, and they are just sort of sat at a bar somewhere next to somebody transmitting to them. And when that person gets sick, they'll think it's flu, because they won't know they've had any contact with somebody who's actually it wasn't even called COVID at the time. This was before there was a name for it. And then I sort of said out loud, if that is the case, then we should expect to be seeing cases in 2 to 3 weeks, which have been transmitted from that person into maybe a more vulnerable population. And 2 to 3 weeks later, Iran happened. And as soon as Iran happened, we knew that was basically the ball game, because it was quite clearly outside, say, China. Now, shortly after that, I flew to Israel, where I was already scheduled. I'd been scheduled for a long time to give a talk to the Israeli Infectious Diseases, the Israeli Infectious Diseases Society. And I was invited by my friend Gili Regev Yochai, who is actually Chief of Infection Control at Sheba Medical Center. And after I'd given my talk, she and I immediately just went over to Sheba, because she had just built an isolation unit, which was built to house the returning passengers from the Diamond Princess. And it's an extraordinary ship. They built it in 48 hours. And while we were there, we were discussing the first thing is I looked at it, and I looked at the work, and I was incredibly impressed by it. But I remember looking at it and sort of saying to her, you're going to need a bigger isolation unit, because, we knew at that stage it was going to be, we were aware that things were going to be getting hard really soon. Well, while we were there, it was quite interesting, because that was when the first imported cases were coming into Israel and contact tracing, and we were having lots of conversations with a number of people at the hospital and beyond about testing regimens and what you should be doing. And I remember instantly at the time holding up what was going on in the United Kingdom, which was at that point doing a pretty good job of like tracking some early household clusters, and I was quite impressed with it. I held that up as an example of the kind of thing you should be doing with people who are returning from overseas. But the pace of things just started changing remarkably quickly. When I first went into the emergency room there was a sign outside saying, and a security guard basically asking the question, have you been in China? And then, or have you been in China or Southeast Asia? The next morning when I went in, there was a new sign there and it was saying, have you been in China, Southeast Asia, or Italy? Have you returned from any of these places? And that evening, when we'd been, it was very long days, I looked in the conference room and I saw that sign rolled up and there was another one going out. And over the course of the day, it had changed from have you been in China, Southeast Asia, or Italy to the one which they stuck with, which was have you come from anywhere overseas recently? And that was over the course of like maybe 2 or 3 days. So there was an extremely rapid change. And then, of course, after that, I returned to the United States. Given the risks of transmission in healthcare, my wife had been somewhat anxious about me going and staying with my friend who was physician treating, patients. But I was actually considerably more anxious returning to the United States, which was just at that stage entering the start of the testing debacle, which we can probably go over later. The final thing I want to say about that time in Israel was that the patients that the patients who were from the Diamond Princess were very interesting because they provided an example of something which has become absolutely evident and very important, which is that they had abnormal chest CTs, but were otherwise minimally symptomatic. I think only 1, maybe 2 of them ever spiked a fever. But they were in a situation where it was reasonable to think they had a pathological process and they were capable of transmission. So again, quite early on, this is evidence that you have capacity for pre-symptomatic transmission or transmission from people who are minimally symptomatic. There's not much kind of link between symptoms and transmission. And if somebody can transmit before they know they are infected, that's the most crucial thing in determining whether something becomes a pandemic. And then after that, I've been basically writing huge numbers of op-eds and trying to do work and keep my lab running. So it was a very intense period, which has only continued to be intense, and every day is a new exponential. I think you may be muted. Zoom is teaching us all kinds of new things about how to do things online.
That actually resonates with me because I remember I was in the A&E and it said the calm before the storm. So that was the word that was going around at the time, at the beginning of the pandemic.
Yeah.
I'd like to go ahead and ask you, what are your predictions now that we've kind of reached the peak of this first wave?
So yeah, I was uncomfortable with the notion of peaks because it can imply that the epidemic curve is symmetrical, which is like an old thing called Farr's law, which some of you may remember. And it's not. I mean, you never expected it to be. There's been a very large period of exponential spread. And you then, if you reduce the transmission rate such that the R number that you've all heard about is below 1, you still have to wait for all of those like infections that you've built up to those little transmission chains to burn out. And so that's really, I think that's something that we expected. Now, the question is everywhere, what happens as we reopen, in inverted commas? Yeah. I dislike, by the way, the phrase lockdowns and reopening because lockdowns are not all alike. There's in Massachusetts, and by the way, I should point out that the population mortality rate from COVID in Cambridge, the city of Cambridge, is higher than in the entirety of the UK at the moment. So, and this is in a situation where we have never had a lockdown as severe as has been in the UK and certainly not Italy. We have always been able to get takeout. You've always been able to go out and walk around on the street. There are now masks mandated, but they were not for a long time. So, but as we offer new opportunities for the virus to transmit, we can expect that it will take them. the obvious question is how quickly that will have an effect on transmission and have a noticeable increase in infections. You should understand, given the generation time, we would only expect to start seeing, doubling time would be quite slow if it is only slightly above 1. If it's a lot above 1, then it becomes much more rapid. So when, in early March, the reproductive number was probably 3 or maybe even 4. So you had doubling times, a couple of doubling times a week. Yeah. Whereas at the moment, if it's just a little bit above 1, the doubling time might be closer to like a month or so. Okay. So you don't expect to see things very quickly. What you might see, depending on the opportunity, and this is a major thing about large gatherings, would be so-called super spreading events.
All right, and is that when people gather together? You're talking about the,
yeah.
Okay, all right. What would be the sensible way forward? At this time, people are opening up. Well, countries are opening up.
And so it's interesting that there are multiple sort of sensible ways forward. So we can look at the likes of South Korea, which has got a remarkable sort of set of testing going on. There's a great example there of a super spreader event. When they opened up nightclubs again, there was a person who went to a nightclub and infected 90 people at the nightclub. And the onward infections from those 90 people I was just looking at this before talking to you, now there's now a total of over 250 from that single super spreading event. They're now looking also, they open schools, but they're now thinking about having to close them again. This is all in an attempt, the South Korean attempt is to really keep it very low. The advantage of that has been the economic impact has been considerably less. It's not been nil, but it's been, speaking in very, very general terms, there's been a reduction of sort of maybe 20% in terms of like traffic in malls or other shopping facilities, but which is obviously an economic impact, but it's much less than what we're seeing either here or in the United Kingdom. Now, the most important thing for places that are reopening, because pretty much nowhere that's reopening is at the level of South Korea. There's ongoing transmission in the United Kingdom. So there's ongoing transmission in Massachusetts. There is increasing transmission in, say, Texas. And I have a suspicion that there's more transmission than is being led on in Florida. So as more opportunities become available for transmission, the most responsible thing that you must do is prepare for what you're going to do if you see evidence of a future surge building. Because Dio, because you've been there, you have seen the way in which, in order for the NHS to cope, it has had to basically redefine what it does. And we're going to be seeing, I think that one of the questions came out about this, and it was a really good question. We are going to see an allied epidemic of other diseases, including cancer, which was not being caught by the early screening, which would have been done because we've had to give it over to dealing with the pandemic. So if you want to avoid that kind of thing happening, you need to be ready to take action earlier. So I think that having, Jeremy Konyndyk has been pretty, from the Center for Global Development, has been pretty eloquent about this. And I've just actually agreed to talk to at a workshop there in a couple of weeks. You want to have triggers which you are prepared to act upon. So you have already prepared your public to say, okay, if we think there's this much transmission and if we think there's risk of this much death happening, we're going to put on the brakes. This is what we'll do. And just be very clear about that. Be very articulate, be very coherent, and start convincing people.
Okay. That goes with goes along with childhood immunizations as well. They all stopped during the period.
Yes.
All right. And how will we prepare for the second wave?
I think the best way. How when you say we, do you mean we as people or the government?
I'd say the government, and we as individuals as well.
I think that as governments, the most crucial thing is what I just said. Having a plan for it. Do not assume that it's not going to happen. Do not. I think that precise predictions are a mug's game. I think it is better to consider where multiple sort of independent lines of evidence align and sort of take a kind of consensus view on the basis of that. That's basically how, that's kind of how science works. So I do not know how much transmission we're going to see over the summer. I would not be surprised if there was not a huge amount. I think, by the way, that the numbers are going to tick up and quite possibly go over 1, but I don't think that's going to produce huge surges. However, it feels a bit Game of Thrones to be saying this, but winter is coming. And we know that respiratory viruses are, including the beta coronaviruses, which we have known about for years, transmit more effectively in the winter than in the summer. Beta coronaviruses are interesting, actually. They don't actually completely stop transmitting in the summer, it's just less. So that's another of the reasons why I don't think we're going to see it die away over the summer months. But so when the fall comes, we're going to be seeing some real potential. I think that then is when we need to be really prepared for what we're going to be doing, what we're looking out for. I believe there may be a question from the floor, but I'm not sure.
There is one. Let's go ahead and see him. It said, curious if there's different guidance for how companies and private entities should engage. So she's curious. Rachel's curious.
Rachel's curious about what? Can you repeat the question again?
Rachel's curious about different guidance for how companies and private entities should engage.
Yeah, it's difficult. When it comes to companies, I mean, all of this stuff has to take account of what you might call facts on the ground. Because your facts on the ground are the amount of community transmission which is going on. So if you have very little community transmission, as is the case in, say, South Korea, then effective symptom monitoring might be helpful. It would be wonderful to have a lot of good, cheap testing, for instance. But I think that companies should engage by working to protect their workforce. I think that it's going to be very helpful if people who can work from home continue to work from home. I think that given that this pandemic is going to last, I don't like good predictions, but given that this is going to be around for altering our lives for, I would say, at least the next year, I think it's a good idea to come up with long-term plans and things that can be maintained for a longer period of time. We don't think that, this is not something this is not in the rearview mirror. No. Yeah, it's going to be coming back.
I mean, from the figures, it says about 5.8% of people in the UK have been infected.
Yeah.
Does that mean that there's going to be several waves to this before all of us are going to?
It depends on whether or not your goal is to get population level immunity. I dislike the term herd immunity for lots of reasons. So let us imagine that 6% of people in the United Kingdom have been infected. Let us also assume that they are all immune, which is probably not true. Yeah. We can come to that in a bit. So that means that 94% of people in the United Kingdom have not been infected. And what that means is that if you were to just resume the kind of normal mixing that was happening in early March before lockdown, if you went back to that, it would reduce the reproductive number by really a very small amount. We would go back to having basically the same, a very similar amount of transmission were we to resume doing exactly that. However, important to note, I don't think people are going to resume doing exactly that. I mean, I think that the kind of contacts that people are going to make are going to be different. And so I suspect that the reproductive number will be lower, but it'll be because of human actions rather than because of immunity.
On a personal level, what should we be doing?
So again, I can only tell you what I do.
Yeah, go ahead.
So
Interesting.
I remember giving this talk on pandemics in Israel. I was just roped in to give it, basically. They still hadn't declared that there was going to be a pandemic, but the team at Sheba asked me to stand up and say, well, what do you do in a pandemic? And that was the point at which I stopped shaking hands. I said to them, you should all stop shaking hands. I mean, at the time I was talking about the whole Ebola fist bump, or, the classical reference, I believe. But I was also explaining the sorts of things that you can do to reduce risk. So the first thing is, you don't shake hands, you avoid being in groups with large numbers of people. Contact outside is better than inside. Wash your hands several times a day. Whenever we come into the house, we wash our hands for 20 seconds and do that several times a day anyway. And if you've been outside for a period of time, change clothes and take a shower. We leave shoes outside. I think the risk of fomite transmission, meaning like things which have been on doorknobs and stuff like that, is actually lower than that of droplet transmission. So the maintaining a distance of about 6 feet is important. 10 feet is better. Things like this, all of this stuff taken together will greatly reduce your personal risk. And I think that the impact of a lot of people doing those things could have significant population benefits. However, not everybody is going to be doing that. One thing I would also point out, masks. There is an emerging science around masks that we don't understand fully yet, but masks preventing transmission are very helpful, and it kind of makes intuitive sense. If the whole point of this being an asymptomatically spread virus is that you should treat everybody, including yourself, as if they could be infectious, then the best thing to do is to wear a mask and protect yourself and prevent yourself from infecting anybody else. Finally, also, I don't know if you've noticed, I scratch my face with something else on here. I try to avoid touching my face. I'm not perfect, so don't pull me up if I do it later, but I started reducing the amount I touch my face back in February.
All right, interesting. We have a couple of questions on chat, and then from there we'll go on to the questions that were actually submitted prior to the event. So let's see. So quite a number of them. All right. Is it Dalal? Any thoughts on overseas travel and risks involved from exposure to flights and the airport?
Yeah, I mean, it depends on where it depends very much on where you're going. I mean, for instance, if you, I know that there have been some suggestions that Iceland might open up and allow people there if they took a test or volunteered to go for quarantine. I think Iceland would be a place where that would be extremely low risk. Similarly, New Zealand. Now, in terms of getting to and from the airport, if you are able to keep social distancing in the same way as you would anywhere else, and that will reduce the risk. Now, being on airplanes, I'm not aware at the moment of very good evidence on this, partially because there hasn't been, it's a little bit, I don't think there's very good evidence so far on this. However, if you look at SARS, the original SARS, there was a very good study of transmission on an airplane from an infected individual. And you could see there that it appeared that the transmission may have been happening more from fomites, because it was like individuals who were going to use the same restroom. So the idea that the suggestion is that people have got things on their hands and then they're going along, being bounced from side to side by the plane, and then they're going and touching that. Now, and I mean, if there are, flights are not as great a risk as people necessarily think they are. But as I say, I would watch this very carefully. The other thing to note, which I said to people on like radio phone-ins back in March, is if you are going somewhere and take note of the state of the pandemic where you're going, and bear in mind that you are likely to be quarantined going there, and you may be quarantined coming back. When I went to Israel, I packed enough stuff to be quarantined for 2 weeks. I assumed that there was a risk that I would not be able to get back into the US. So, I mean, I would bear those things in mind if you're traveling anywhere.
Okay. And then there's another one by Angeline. She says, could you comment on the aerosolized versus droplet infection when it comes to COVID?
Yes.
What's the difference of this type of transmission to loudspeaking and plain wind instruments?
So there's these are very important things. There's a good kind of, this is a great question. So aerosols are what you would ordinarily associate with airborne transmission. Now, when we talk or breathe or sing or do any of those things, we generate small droplets of varying size. And whether or not something is classified as a droplet or an aerosol depends basically on the size of the particle. Now, droplets are large enough that they fall to the ground around 6 feet away. Around, I don't want to be, I mean, it's not that there's like a wall at 6 feet and then they just go. It's that there is actually a sort of distribution. It becomes, you know, that's why I'd say 6 feet is good, 10 feet is better. And that's where that advice comes from, because most of the transmission appears to be in those droplets. And if you're like sort of talking to somebody, inhaling their droplets for 15 minutes or so, that makes transmission that much more likely. Now, people have said that aerosolization, the smaller droplets, is...
Oops. What's happened? Lost you. Hello, lost you.
It's not.
Yeah.
Yeah, it's back.
Oh, okay. So I don't think that airborne transmission of that kind happens enough to be a major influence on transmission. That's just saying my internet connection is unstable, which could be, we have a very good internet, but we have a lot of phone calls going on in this house. And so hopefully it won't be too much of a problem. Now, so we have actually got studies which have detected the presence of virus in aerosols. And interestingly, now the question is whether or not that is viable virus. And it appears to mostly not be. So you can detect the viral RNA, you can detect the genetic material, but it's not actually transmitting, it's not actually turning something which is potentially transmissible. So that is the state of where the science is at the moment. But as Angeline says, if you are singing, you are not only potentially generating large quantities of droplets of many different sizes. If there are aerosols and there is a low risk of aerosol transmission, you'll be making it higher by singing. You will also be drawing it deeply into your lungs. And as you do that, you are more likely to get transmission of the droplets, not only into your lungs, but into the deeper parts of your lungs, which could have an impact upon the severity of the infection. So I would, you know, there have been several super spreading events which have been included around, you know, church choirs and things like that. So I think that those are sorts of activities that for the moment really should be kept on hold.
There was actually a question that was submitted about some countries saying 1 meter distance, 2 meters distance, social distancing. Is it a standard 2 meter social distancing?
So yeah, as I say, the standard is to say that it's 6 feet. Or sometimes people say, I've heard people say a tapir, or in Canada they say a caribou, in order to come up with some sort of locally relevant animal to compare it with. So I think 6 feet is based on studies of where droplets fall, but you know, the more, the better. If you think about the WHO mission to Wuhan, which is actually, it's worth reading about the things that they did there. When they had meetings, in order to avoid talking loudly, they sat a long way apart from each other and they talked into microphones.
Another question from Vicky, who says, COVID affects individuals differently, age, gender, ethnicity. Can you give your comments on this? How can governments implement policies around this?
Yeah, this is a tremendously good question, and it's one which is, creates tremendous challenges, because there is as Vicky says, there's huge variation in the risks to different age groups or people with different comorbidities, and possibly, I mean, it's early because you have to disentangle a lot of the different factors. You know, all people who've done sort of causal inference and stuff at the Chan School will remember this. Possibly certain ethnic groups as well are more at risk of severe disease. We're going to be learning more about that. Now, there is a stated aim by many governments that they're going to protect the vulnerable. Now, this, I have to say, it's very difficult to see how you can protect the vulnerable in a situation when you have large numbers of the people, of the population infected, and asymptomatic transmission is a thing. You can see this, I think you have a question later on about the Swedish experiment, so we may leave this until then, but this is a respiratory virus which transmits from the pre-symptomatic state. It is very, very difficult to come up with a completely free situation which is compatible with full economic, activity that does not place at-risk populations at extremely high risk. You cannot really keep them out. So in my view, the better way to do it is to both do everything you can to protect people with excellent public information. I mean, I can tell you that the advice that came to my in-laws was received at a point when they were saying that, you are at risk, came at a point when people had already been dying. So it was rather shutting the door after the horse had bolted. I think that what we need to do in response to the question is to come up with effective social distancing. Not all things are equally important. Because this almost certainly has an over-dispersed reproductive number, it could be very effective to reduce the likelihood of super spreading events. And it may be that that can be done by relatively simple steps, such as mask wearing or avoiding large gatherings. So the problem is lockdowns are a blunt instrument which became necessary in multiple places because a large sort of tinderbox of community transmission had been allowed to build up that was going to slam into healthcare and have devastating consequences. Now we know more about it, hopefully we can come up with ways which are more effective of doing that. But I'm sorry I can't give more precise answers, but I hope that my answer is giving some guidelines for the kind of questions that you should be asking.
Okay. All right, we'll go on to discussing submitted questions. I think it's fair that we should actually go on to those ones. So I'll pass you over to Stefan and let him begin.
Thank you very much. Do you mean the ones in red or the ones in black there?
Start on any one, whichever one.
Yeah, okay. One you would like to hear the answer
to. Thank you. While there are quite a lot of questions and we are mindful of your time, but there was something here around people who have no symptoms and asymptomatic patients contaminating others, and about the length of time that it might take for being infectious in terms of before the symptoms show up potentially.
So yeah, this is not yet even submitted, but I have a paper draft which I was sent at 3 in the morning because people are working it all out, which is based upon analysis of some early case series from Hong Kong, China, and that kind of relatively well-studied transmission events where we think we know who infected whom and everything. And we estimate that between 60 to 80% of transmission happens before symptoms develop. That's that's quite a lot. I mean, we should also note that we knew quite early on, January, February maybe, that within those cases, like I think it was 10% of transmission events, the only contact between individuals was before symptoms developed. So it had to have happened then. So we've known for some time that it was possible. But as I say, it's in that unmitigated period of the pandemic, or relatively unmitigated, the amount of transmission before symptoms was very high, easily the majority, 60 to 80%. Now, how long that happens for depends obviously on when symptoms develop. Now, the serial interval, which is the time not between infections, because we normally don't observe the infections, we don't know exactly when they happen, but serial intervals are the time between when cases are recognized, is about 5 days. So we can sort of realize that it is that asymptomatic sweet spot for transmission is probably only lasting a couple of days in those people because, you know, they have become infected. We assume that they're not able to transmit on the first day, but second or third day, they start producing virus, and then they start developing symptoms, and then they report for testing, and then they get identified, and so on. So we are beginning to, so it's early on in infection. Now, what I will say is that we still have a very poor handle on exactly how many, on the actual course of infection in a very large number of people. Because, and as with so many infectious diseases, when we start looking into it, we see the obvious things, we see the severe stuff. And so we base what we're doing on the severe stuff. And like I said, back in January, we were endlessly wondering, scratching our heads about how many mild cases are there? I mean, still, we don't really know. I've been trying to get an unusual serological sampling strategy off the ground in which you would actually start using serology on contacts of known exposures sometime in the past to try and see how many of them might have actually been infected and nobody ever knew. Because if that's the case, if you can have people who are sort of asymptomatic for a longer period of time, perhaps, and I'm saying I should point out this is speculation, perhaps those individuals might be important for some of these super spreading events that we've been talking about. But I think we need to do a lot more work investigating that.
Thank you. That's very sobering, actually. And it shows also how important it is to have early action in this pandemic.
Absolutely, absolutely. Early action is what, you know, many people misrepresent epidemiologists as saying that they want to have lockdowns and they hate the economy. And that's not actually true. Lockdowns, as I say, are a blunt instrument, which are necessary under exceptional circumstances. If you're smart, you can manage to take milder. If you're very smart and very prompt, you can manage to do what some countries have, you know, mostly island nations, I will point out, and manage to throw the virus out again. If you are unable to do that, and it is at an early enough stage in the pandemic, then you can mitigate it with milder interventions. But if you basically allow it to transmit to the point where you've got a very large fraction of your population already infected, and the people who are going to die in a month don't even know that they're infected yet, then that's a situation where you need to take very prompt action.
That makes sense. One of the next questions is actually about the Swedish experiment, between brackets, and about the rationale of shielding or isolating those in the vulnerable groups and keeping the rest of the country more or less active.
Yeah, so, and this actually is, the Swedish experiment sounds, the Swedish experiment has been extensively reported and often misrepresented. So let's go into that. I mean, the notion in Sweden is that you can prevent the health service being overwhelmed by mild social distancing implemented early. So this comes back to what I was just saying, actually. You know, implementing mild social distancing earlier on in the pandemic means that you can prevent threatening your healthcare. But it's not that they've done nothing. They have, I believe it's events larger than 50 people are not permitted. People are advised to practice social distancing and encouraged to work from home, and a large number of people have. They have also closed high schools and universities, which are, we believe, important sort of foci of transmission, because that age group make a lot of contacts. In fact, there's a paper in Eurosurveillance which came out yesterday, which showed that after the German shutdowns and restrictions were put in place, serology in that age group actually increased proportionately, suggesting they were continuing to make more contacts. So Sweden's experiment is kind of, it's not lockdown free, but it is lockdown light. The idea was that you could then protect the vulnerable population. Let's see how this panned out. In the week to June the 2nd, Sweden had the highest per capita mortality in the world. So it hasn't proven, and a per capita mortality which is around 10 times that of other Scandinavian countries. And fully 50% of those or so have been in nursing homes and care homes. With reference to the earlier question, you cannot insulate vulnerable populations entirely from a large amount of community transmission of an infectious virus which transmits via an asymptomatic route. And it's not only Sweden that's seen that. 60% of deaths in Massachusetts have been in care homes. In fact, I would say that I did some very rough calculations last week, but nearly 10% of the Massachusetts nursing home population is already dead as a result of the pandemic. So protecting these populations is of utmost importance. But if you allow a large amount of community spread, it becomes more difficult. A similar proportion of the dead in Norway have also been in nursing homes. However, because Norway has not allowed a large amount of community transmission to get started, the numbers are smaller. So Sweden's experiment should be a cautionary tale. In effect, they've ended up as being something of a control arm in the trial of different sorts of interventions.
Thank you. That's very sobering.
Almost everything is these days.
How are we with time? Are you okay with time for a few more questions? Or
I'm okay for a few more questions.
Thank you. Dayo, would you like to ask a few more from the list?
All right. A couple of other questions, and this one has come in. It says, what's the evidence for mutation of the virus?
So yeah, evidence for mutation. I actually wrote a thing. By the way, you can find the Center for Communicable Disease Dynamics does have a web page which you can find, and you can, me and Mark, Caroline, and Mike all have fairly active Twitter accounts. But if you go to the webpage, you can find some blogs that we wrote, or links to them, including things on how to report the pandemic responsibly. And one from early January, which I wrote with a postdoc, Jieting, on mutations. The virus is mutating. This is not remotely surprising. It's what viruses do. The amount of mutations that it has built up are consistent with a common ancestor around about the time of Thanksgiving last year, which is also consistent with the early reports we get from the seafood market in Wuhan. Interestingly enough, given what we now know about the virus and the fact that so much transmission is mild, it is reasonable to think that there could have been ongoing transmission before then, but which we have not been able to pick up, and we only noticed it in the seafood market because there was perhaps, you could speculate, a super spreader event there, which led to a large number of cases. Anyway, coming back to that. The mutations that have arisen are sufficient to enable us to do some reasonably good tracking of it and estimate the time of introduction to various places. But this is fraught with difficulty because there's very little variation so far. There is mutation, but when it comes to RNA viruses, which normally mutate like the clappers, this is comparatively stable. And that makes it quite hard to draw inferences about exact introductions. So you'll remember that Trevor Bedford, or you may remember that Trevor Bedford back in, I think the end of February, made the announcement that the virus had been transmitting in the States for 6 weeks on the basis of the first sequence from Washington State, which was only 2 mutations different from one which was sampled 6 weeks later. And he said that, the one that had sampled later had mutated twice on the way to that. That now appears to be mistaken. It now appears that they are from the same lineage, but they actually represent separate introductions. So working with the mutations is it's very hard. But I think the question is also, looking at, is there sort of evidence for it becoming more or less dangerous over time with mutations? And there isn't really any evidence of that at the moment. The apparent association of some lineages or mutations with particularly severe outbreaks, or indeed less severe outbreaks, can be explained by the virus which happened to be circulating at the time the outbreak was taking off, as opposed to later. So people proposed that the people proposed that the variant that was in New York City was more virulent on the basis that it caused the outbreak in New York City.
Yeah.
But if you actually look at the amount that contributes to disease in Washington state, you will see that it declines following social distancing at exactly the same rate as the other variant does. So there's not really evidence for any difference at the moment. Now, that's not to say it cannot occur, but we just don't have any evidence for it at the moment.
What's the implications for the vaccine development?
That's a very good question. So, in flu, which mutates very quickly, we need a new vaccine each year because of the fact that it mutates in order to be able to evade the current vaccine and current immunity. Whereas this, we don't think it will mutate to be able to avoid a vaccine. One of the other things which is important is that we need to remember that that type of mutation is what we call diversifying selection, because the virus is mutating to be diverse and be different. There's no selection for anything being different in the virus at the moment, because there isn't any immunity to speak of. And so we don't expect to see those kind of changes. If and when we have a vaccine, if and when we have large amounts of population immunity, then we expect to see different evolutionary things going on. But that time is, I think you can understand, quite a long way off.
Yeah. There's quite a number of questions coming in about the university starting in September.
Yes.
And what's your take on that? Then
Well, as I said, that age group is particularly involved in transmission. I think that however, it is also true that universities, want to be able to do in-person classes, and that's an important, even though we're getting good at distance teaching and distance learning and, Zoom, although I'm sick of Zoom, I don't know about you. Sorry, not right now. Now is fine. I spend a lot of time on Zoom calls. I'm sorry, I don't know if you can hear ambient noise, but the trash is being collected. So if you hear any loud trucks, and that's why. I am deeply worried about universities and the capacity that they might have for transmission in an age group which, while themselves are not particularly vulnerable, it seems, they might be, they can transmit to others. So I think that hopefully by the fall, and anybody that's going to be planning on doing this, there's going to be a good deal of testing. There's going to be a certain amount of, there is going to be the capacity to allow distancing, although that age group doesn't really do distancing. And, dorms are going to be difficult places to be living in. I mean, you can't practice social distancing. Singapore was doing so well until there was an outbreak in the migrant workers who were in dormitories in which they could not practice social distancing. And we want to remember also that that age group, while much less likely to get severe disease, is not at zero risk. Yeah. I have text messages from a young, 30-year-old healthy man who was almost certainly infected as a sort of couple steps on from the Biogen meeting in Massachusetts, saying that this was the worst infection he'd ever had. He felt terrible. He wished he could go back in time and warn people about it. Yeah. So I think we're going to need to be looking at it, and I'm very carefully. And I'm anxious when I hear people talking about reopening as if, as I say, the pandemic's behind us. Given the reproductive number, given the capacity for transmission within normally mixing communities of the type that we had up until mid-March, then you would need to have maybe 60% of the population to be immune in order to bring the reproductive number below 1 due to immunity. Now, it might be a little bit lower than that because there's probably some variation based on the heterogeneity of the population, but it's emphatically not anything that we're going to be close to, even in New York City, where we think that about 20% of the population has some signs of immunity.
And something applies to the houses of worship as well? Yes,
absolutely. I need to actually, that's a good point, I need to write to a friend and sort of say to him, you're not opening your church again, are you? Absolutely. While I understand that people would want to be able to go to them, I think that we have to be very careful. We have to also remember that the potential risk to different age groups. I know personally of at least one person who died. The only contact he made outside the house was to go to church. And that was I don't know that that was a link, but obviously it is a very plausible one.
Just to say, testing. That's what the WHO guy says.
Yes.
How much testing should we be doing?
Lots.
Should offices be testing their workers before returning?
Well, I mean, the question, are you talking, which type of test are you talking about at the moment? Are you talking about the serological test?
So both the serological and the antigen.
So, I mean, I'm sure you all know this. I'm sure you all know this, but the distinction between the tests is that the one based on PCR tells you whether or not you have genetic material from the virus in wherever the swab was taken from. So, sort of anterior nares maybe, and or the nasopharynx. And it is they are reasonably good. They're not perfectly sensitive. They are most sensitive early on in infection, and then they sort of decline as time goes on. So if you've had symptoms for a few days, you go and get tested and it comes back negative, it doesn't mean you didn't have COVID. The other test is a serological test, which determines whether or not there are antibodies. You can get that about 3 weeks after the infection occurred. So 3 weeks after infection, antibodies can be detected, roughly speaking. Now, people who have antibodies, those tests are quite difficult. For a start, many of them have a relatively high false positive rate because they get confused with immunity to the other coronaviruses. Secondly, just because you have evidence of infection doesn't mean that you're immune. We are now getting better stuff on the titers of neutralizing antibodies, meaning the type of amount of antibody in the blood that would actually generate immunity. We're getting more evidence on that. But lower amounts of antibody will not prevent you being infected again. Now, we don't know whether or not you will be as severely affected as you were the first time, or we don't know whether the risk of being severely ill are going to be less if you have low levels of exposure already. Mm-hmm. Because of a phenomenon called antibody-dependent enhancement, it is plausible that people with low levels of immunity could actually be worse, more severely affected the second time they get infected. We know that's the case with dengue, for instance. Yeah. And that has been reported for other coronaviruses. Whether or not it's happening here, we are not going to know. Unfortunately, I think we're going to be finding out the hard way. Yeah. So if companies have been able to do tests and find that somebody does have, sterilizing immunity, protective immunity, something which is going to enable them to be very unlikely to be infected, that's a useful thing to know. However, I don't think that in and alone and of itself is going to be sufficient to be very careful with those kinds of test results. Not least because we really don't want to tell people, in particular people who are at any kind of risk, that they have had COVID if they haven't, because that'll place them at risk in the future of getting it.
All right. School openings. How do you feel about that? It's probably the same as university as well. Oh.
So the school opening is interesting because I have to write a Twitter thread about this. I've been planning on doing it for several weeks now, and I haven't, and I keep taking in additional data. So adolescents, I don't think schools should be reopened, or only very, very cautiously, for the same reasons as I'm concerned about universities. Yeah. If you look at adolescents, they appear to be involved in transmission, disproportionately likely to be seropositive and so on. They're also of an age where it's probably easier to do distance learning. Now, the younger age groups, we need to remember, schools do a heck of a lot more than just teach. I mean, they are, in the United States, are important sources of nutrition. Some children are safer at school than they are at home, even taking the coronavirus on board. And the question is, there's this crucial question: to what extent are children involved in transmission? And this has been confused by the fact that children get less severe disease. And because, as I said, in the early stages of this, we were kind of detecting cases by looking to see who was ill, that means children were underrepresented in those case series. Now, it didn't mean that children could not get infected. And early reports from China, from places that were less scrambling to handle the outbreak than Wuhan, reported that kids could become infected. And data since then has confirmed that.
Yeah.
The question is, to what extent do they then contribute to transmission? And there are good reasons to think they might not. I mean, I'm not this kind of biologist, so take this with a pinch of, look into this more. But I believe they have lower levels of the relevant receptor, the ACE2 receptor, which may make it less likely that they become infected, and it may make them less likely to transmit. However, the studies you have seen are confounded, because many studies have been done on household transmission. Now, in the first place, household transmission is not the same as school transmission. These schools are very different. I saw a UK official whose name I will forget, announcing that she did not think that any students would share food, any kids would share food at lunch, and that's just abundant nonsense. I know for a fact my daughter, my daughter trades her lunch with loads of other kids. It's a tremendous opportunity for transmission. Now, the cases in households are biased because of the fact that if your index case is determined by the one that you notice on the basis of symptoms, it's more likely to be an adult. And if you then go back as a result of identifying that person and start testing everybody else in the household, and you find that children are infected, you think that the adult infected the child. But that may not be the case. It could be that the child infected the adult, but you noticed the adult first. In fact, it could be even worse than that, because, as I said, the tests are most accurate early on in infection. If the child has been infected but has since cleared the infection, then you'll be thinking, oh, the adult is infected but did not transmit to the child. Yeah. Because you have failed to pick that up. And there are very, very few studies that have adequately controlled for this. The best, I think, come from China because of the fact that the extremely stringent sort of quarantines which took place there, in which you were able to sort of, the initial family member would be isolated, and then the family would be followed in order to see if anybody then became infected subsequently. And you can then sort of see repeated testing over time, people then becoming infected at a later date. And those data, I think, suggest that children are less likely to transmit, and they are less likely to become infected. But it's not zero, it's just less. And the result of this is that given the types of contacts that children make in schools, there is a capacity for school reopening to have a significant effect upon the reproductive number. There is at least one paper, I think it's in Science or Nature, one of those one-name journals, suggesting that reopening schools could, on its own, increase the reproductive number by 0.3, which is what one as well.
Interesting. That's good. At least the young ones get to continue to learn.
Yeah.
Just two more questions, very short. What someone mentioned, asked this question. What's the probability that the coronavirus, the COVID, will die out in the next couple of months?
No.
No. And the other one is it like that COVID-19 evolves into a chronic disease for those who were infected?
I don't think it's going to develop a chronic disease, but if you want to look at the, there was a very good interview with Peter Peart, who is one of the people who discovered Ebola, and who was recently infected. He was in intensive care. He, many weeks later, was still recovering and having difficulty climbing the stairs in his home. Now, he has recovered from the virus, but unfortunately, it's not that there's going to be a chronic sort of disease, but we don't know the long-term sequelae of infection because there hasn't been a long-term yet. We know again, the UK was among the first places to report this, that you can see things like the Kawasaki-like syndrome occurring in children. It's rare. If you allow enough kids to become infected, you will see rare things. I think the long-term consequences are going to be something we're going to have to watch very carefully.
I'm aware that the CT scans have shown fibrosis of the lungs.
Yes.
So
that's absolutely true. If you look at, you can see abnormalities on CT after people. I just noticed there was a question in the chat from Rachel. I just wanted to say to her, that is a piece of work that's been being done in my lab. If you want to get, which is not yet even a preprint, keep an eye out and I will say something about it. If you want to get data though on that, there have been papers which have been published with similar sorts of estimates, roughly speaking, from the Hong Kong group with Gabriel Lun, Ben Cowling, and those kinds of people. So if you want to find them, then that's a good source of information. It's broadly speaking consistent, but I think we are able to be a little bit more precise.
All right, thank you very much. I'll hand over to Stefan to give the closing remarks. Thank you very much.
Thank you. So, like I said, say hi to Shirani if you see her.
I will.
Thank you. Thank you very much. It was a real privilege to have Bill Hanage with us today. And thank you very much for this excellent opportunity. We learned a lot. We had a lot of questions that were answered, and we have a lot more to reflect on and take back with us. There were a few more questions on the chat as well that we didn't have the chance to get through because of the limited time constraints, but we are going to provide additional web resources together with the recorded webinar online in the next few days. I would like to thank everyone who supported us today, especially Dr. Hanage. Thank you again. Thank you for all the hard work around the logistics of putting this event together, to the Office for Alumni Affairs of Harvard T.H. Chan School of Public Health, especially to Director of Alumni Affairs, David Rogers, and his team, Marielle and Megan. Huge thanks to DIO and to the Harvard School of Public Health Alumni Council, and to all the members and friends of Harvard Club UK, especially to Yuko, Vicky, and Verity, and to the Harvard Alumni Association. This event was the first joint collaboration between our clubs, and I'm sure that many more will follow with exciting and timely topics with wonderful speakers, so stay tuned. Thank you again to everyone who attended today. I wish you all well, stay safe, stay healthy. Thank you. Yeah.
As I often say, take care of yourself and others.
Exactly, very nicely put, thank you.
I'm going to leave now. Thank you to everybody. I really look forward to, hope everybody else, hope the rest of the pandemic goes smoothly. But yeah, we'll keep working to do what we can.
Thank you very much. May we bring you an email with some of the links that you mentioned just to check, and we'll add them as resources?
Sure. I will do that. And you know, as I say, we are at CCDD. We are relatively active on Twitter.
I'm following you.
I'm a Facebook refusenik, but we're relatively active on Twitter, and it's that's a fairly good way to understand exactly what we're thinking right now.
Perfect. Thank you so much.
Take care, guys.
Take care. Thank you. Bye.
Thank you.
Thank you.